Gastric cancer, you have first-line setting where patients present de novo with metastatic disease, and you have patients who've received prior adjuvant therapy. So I'll discuss second-line setting as well. Third-line, very little data available now except ramucirumab, which is not available in India. So I won't discuss that much. And then targeted therapy. First-line chemotherapy, what should be the standard of care? There is a meta-analysis published, basically, which shows that polychemotherapy is better than single agent. Combination of 3 drugs, which has an anthracycline, is better than infusional cisplatin 5-FU, and a 3-drug combination is basically better than a 2-drug combination. So REAL-2 was the pivotal trial which randomized patients into 2x2 into ECF, which is standard of care in most centers. Cisplatin was replaced with oxaliplatin and 5-FU was replaced with capecitabine. Again, to try and see, this was a non-inferiority trial, to try and see if these were equivalent and for patients' quality of life, whether we could replace these, as I've said before. And as you can see, the arms are pretty much overlapping each other, but for EOX, which is epirubicin, oxaliplatin, and capecitabine, the survival was the most significant and the best. The rest of them, the median overall survival is about 9.9 to 9.3 months, but it was 11.2 months for the EOX arm. So it fared the best compared to the other 3 regimens. The other drug, which is quite interesting in first-line metastatic setting, because we know epirubicin is cardiotoxic, and most of the patients, the median age of presentation of gastric cancer is usually above 60 to 65 in the Western studies. And you want to avoid anthracycline if possible because of comorbidities of diabetes and hypertension. So to try and replace epirubicin with docetaxel, this was a first study which looked at DCF versus CF and showed that adding docetaxel to CF actually leads to a significantly better overall survival.